Protruserati, that's a wrap for 2025. Thank you for bringing us into your commutes, into your workouts, into your onion chopping sessions, and into your gardening. Team Protrusive were there for you when you were really thinking hard about this one specific case and you wanted that little nugget from a specific podcast episode. Or maybe you listened to us in the morning on the way to work to get you in the right frame of mind to pump you up and make you feel enthusiastic about dentistry again. Or maybe the flavor episode you like is our interference cast, our non-clinical episodes, and there were some cracking ones this year. Whichever ones you enjoyed, whichever way you enjoyed it, thank you so much for being a Protruserati. Just this year alone, we published 44 PDP episodes. Those are our longer, meatier clinical topics. We did 7 student episodes with Emma, and the great thing is that this year we also introduced CPD because we realized that dentists were also listening because it's nice to break things down to basics once again. The basics can never go out of fashion, and so we introduced CPD quizzes for even our Protrusive student episodes. Not for the students, but for the dentists who tune in to those episodes, your time is validated with CE certification. And finally, we did 11 non-clinical episodes. And I know how many of you messaged me to say that actually those are the ones that you really look out for. And everyone's different. Some of you never listen to those ones because you are just in love with clinical. Some of you listen to every single episode, and we thank you so much for being such a devout Protruserati in bleeding protrusive blue. Now, this episode's a fun one. We've kind of taken the best bits of 2025. It is 6:30 a.m. on Christmas Eve right now, and I'm getting this recording session in. This episode will be out to you next week, so by the time you listen to this episode, I'll be away in Dubai with family. I'm also going to Amritsar in India for 2 days to see the Golden Temples with my family. I'm so excited for my kids to see it, and I hope whatever you're doing this Christmas festive period, I hope you have a great one. Now, the reason for telling you all that is, well, that's why I'm up early on Christmas Eve to make sure that this is out for you in time, and I want to thank my team for working around the festive break to make sure we have a cracker episode to finish off the year. But the other reason I'm telling you this is because I am desperate for a break. Since we launched the podcast in 2018, I don't think we've gone more than 9 days. Like at one time went 9 days. Usually it's like 7 days. Just one point in the 3-4 years ago, I went 9 days without posting an episode. And so we haven't done seasons and like take a break for a month. We've been flat out publishing podcasts. I think we did 9 or 10 in November. And I'm not saying that, oh, we work so hard, feel sorry for us. It was a pleasure. It was an absolute pleasure to record those episodes and bring them out to you. And as a team, our mission is to make dentistry tangible and to support you. Whether you're a student or a seasoned practitioner, we are here for you. But I can't deny that I need a break. So really cool thing with this episode, obviously this is me talking to you right now, and at the end I'll say goodbye to you, but all the middle bits of the episode, all the narration is AI. It's the Jazz AI. It's Ask Jazz. So if you didn't get my emails or you didn't see the socials, we have just launched Protrusive AI, and it's called Ask Jazz. And AI Jazz is really clever because AI Jazz can speak Italian, can speak Chinese, can speak Finnish, Hungarian, all these languages that I can't. And it's basically an AI kind of like ChatGPT, but it has boundaries. Because ChatGPT has no shame, it can make mistakes. It doesn't understand the nuances in dentistry, and it's actually a very regulated profession, and it can't just make stuff up, which if you use ChatGPT enough, you'll realize that a lot of the stuff is eyebrow raising. It's like literally making it up. Like think of like names of authors just completely made up. So we've taken every single thing I've ever taught, contributed to, ever learnt myself, and of course the entire backlog of the years of episodes, and we made our own AI. And the way this is powerful is that if you ask it something and it doesn't know, it hasn't had training on, it's not going to make it up. It's not going to give you a BS answer. And we could allow it to deviate a little bit and access everything that ChatGPT has, because this is AI, it can access all that kind of stuff, but we've given it strict instructions to make sure that everything that we share on Protrusive AI is in the frame of, if you're sure, share it. If you're not sure, don't make stuff up. And that's just like the foundations of Ask Jazz. Ask Jazz is just full of absolutely every single thing we've ever done in the entire Protrusive ecosystem. It's there for you when you're about to fit a bridge for a patient and you're trying to ask, how do I condition this metal for best adhesion for this Resimine bridge, for example. Instead of having to tune in to one of my lessons or one of my courses, you can just ask it. It's got access to all of my courses and all of the episodes, and it will tell you the reference of the exact bit of the episode, the exact transcript of the episode, so you can have absolute confidence that what we're sharing with you on Ask Jazz is validated by us through our education. So over the last week, the founding members had the first access to it. And it's been great to have the early feedback, and we're tweaking it to make it even more powerful. And then on the 29th of December, so I think yesterday, all the Ultimate members got access to this. And you can access it on the app. Like, it'll always just live on the app. So you don't have to like open up ChatGPT separately. You can chat with it by text, or you can call me. Literally, you can call me 24/7, and in my voice, in your language, I will speak to you. I had Dr. Sherry the other day. She just messaged me saying that she was speaking to me, and in my voice, I told her the exact prescription she needed to do a B splint prescription, so type of splint, and like, what should I write in my lab docket? And apparently, I gave it to her, and she was really happy, and I taught her how to now go from the call, the voice conversation, to the chat transcript, so she can copy and paste it and send it to a lab. Remember, whether it's occlusion, splints, bonding and onlay, doing a veneer lay, the stages for a wax jaw registration for complete dentures, everything is in there without any copyright breach, because there are some LLMs out there that will breach copyright, and they've put all these like textbooks inside, and that's not legit. Plus, textbooks go out of date. What we are doing is we're constantly updating it. And I know you guys are already blown away, but I think that Protrusive AI and Ask Jazz is just at 20% of where it's going to be in 6 months' time, because we're really throwing the kitchen sink at it. So yeah, long story short, most of the episode is narrated by Ask Jazz, i.e. the AI Jazz, not by real Jazz, so that I can have a break. So maybe I shouldn't have told you that. Maybe I should have revealed it to you at the end, so you can see, oh my goodness, I can't believe that was the AI Jazz, because you'll see it really does sound just like me. And so yeah, it's a mishmash. It's a mishmash of all the best bits of the year. The very first thing we start off with is with Dr. Hans. Remember Dr. Hans? We did the reverse dial technique. In that episode, we talked about how to manage localized posterior tooth wear, not anterior, posterior, and how to do it without complex rehab. We can utilize some lessons we learned from the dial technique and apply it posteriorly. There'll be a nice reminder if you already listened to this episode, and if you haven't, it may whet your appetite to go and check these episodes that we referenced throughout this Best of 2025 series. It might actually fuel you and inspire you to want to learn more. So let's start with Dr. Hans, and let's work through with the AI narration of Jazz. Some of the best bits, these are not in chronological order. These are like, we go from restorative to aesthetics to communication. It has a nice little flow. So I'll catch you, the real Jazz, we'll see you in the outro. In this episode from August about the reverse dial technique, I asked Dr. Hans Christian Ognedal how he manages localized posterior tooth surface loss without complex rehab. Here's the moment Hans explained the modified dial approach. Let's imagine that example case that we've imagined, the posterior localized wear. And we've said that, okay, this patient has probably a brachyfacial face, strong muscles, silent reflux, and they've managed to see their GP, and let's say they've controlled it. And now you're looking to treat and plan this case because this patient's young. The primary reason to treat here is not aesthetics. It's far from it. It's to preserve their teeth, to make sure that they will keep their teeth for as long as possible, right?
Preserve the teeth, but ultimately also to preserve aesthetics and functioning, because if you lose your molars, it will inevitably hurt your front teeth over time.
Your patients complain of sensitivity?
Yeah, then usually I do an impression just to have a model so I can have a look at the model. And the way I do the reverse dial or modified dial, it's a direct technique. So after I've assessed the models and I've checked the curve of SPE and checked if are there any interferences for the teeth to either erupt or intrude, and we'll have to have a chat about eruption and intrusion after this one. Then I build up to, usually when you're worn down to the dentin, you've worn about 2 millimeters off the molar cusps, because young molars and young healthy molars, they have about 2 millimeters of enamel on top of the cusps. So you know, if you add back anatomy and use anatomy as your guide, you will add about approximately the right amount of composite to the top of that tooth for the composite to be fairly wear resistant, to not break.
Next, in June of this year, I asked Dr. Marco Mailino why injection molding consistently outperforms traditional layering. His answer, it all comes down to creating a sealed pressure chamber. Here's Marco explaining the number one thing dentists should do to get void-free and perfectly adapted composites.
So I never take material with a spatula and I put somewhere. So if I have to do edge bonding, what I do, I want always to have some matrices. In easy cases, I put body strip, for example, you know, the blue transparent matrices, they are very easy. Mm-hmm. I put that. So that I do what? I always want to have, David Clark talks about having an aquarium, a chamber a place where you can inject with some pressure heated material. So what I do in all my cases, small restoration, big restoration, I always want to have something like a chamber, an aquarium, where I can inject. Of course, in simple cases, this most of the times means to have maybe just a body strip matrix just wrapped around the tooth or around that area, and maybe I just stabilize with some Teflon, some liquid dam, or with some flowable in order to have. But I always try to do a small chamber.
In April, I uploaded my own veneer lay prep walkthrough. Many of you asked how I'm stabilizing PTFE so precisely. Here's the exact moment I share the 3-step technique that I use to get my PTFE where I need it. Dry tooth, wet instrument, and perio probe. The way to do it here is use 2 instruments. I've got a probe in my left hand and I've got a cord packer in my right hand. And what I'm doing is I first dry the tooth, okay? Because I want that to be super dry, and I want my instrument to be wet because the PTFE will go towards, it's like hydrophobic, so it will go towards the dry area and away from my wet instrument. So once I've got that dry tooth, wet instruments, here's what I do. I keep my probe in one place, okay, and I use my cord packer to sort of pack it in. As you can see, it's like this kind of motion, and then I move my probe along, and I again move my cord packer along, and then you can see that little trick here. You just like sweep around with your cord packer. The purpose of the probe is the following, right? Have you ever tried to do this, right? And if you're just using one instrument and you're going around, as you move forward, and let's say you get to the distal, as you're pushing that PTFE in, the mesial is lifting up. It's the most annoying thing ever. So the purpose of the probe, or a perio probe, anything you want to use, is to stabilize the PTFE while you are continuing to place it with your cord packer or flat plastic. I'm not religious about which type of instrument you use, but that's a top tip there. Wet instrument, dry tooth, probe to stabilize, cord packer to work it around, and as you can see, really do get a lovely isolation here. One thing we can all agree on is that bleeding margins ruin dentistry. So at the beginning of the year, I uploaded this quick clinical tip episode. I demonstrated one of my favorite tricks, the hemostatic oblique wedge technique. Here's the exact clip where I show how it stops bleeding instantly. Let me show you how I use the hemostatic oblique wedge technique, okay? So I know the bleeding is more mesially. So what I'm going to do is I'm going to stick the wooden wedge in, not straight, okay, not straight like normal, not like that, okay, but I'm actually going to angle it upwards, okay, and go in a more oblique fashion. So I'm angling that wedge in a little bit more, and it's actually compressing right into the gingiva. It looks pretty straight here actually, but remember when I was doing it, I was at an angle, so I was at a bit more of an angle than going when you traditionally go in. Okay, so instead of the normal way, you're just angling it down. The tip of the wedge is being angled down towards the gingiva a bit, right? And you can see here how my wedge is very much subgingival, right? It's actually wherever that annoying capillary was that was bleeding too much, I have completely compressed it, okay? I have strangulated that capillary, and look at it, it's pretty much instant, right? How cool is that? That we just stopped all that bleeding without anything fancy with just an orange wooden wedge. Fast forward to April. In our veneers episode, I asked Dr. David Bloom what single factor most determines long-term veneer success. Here's his timeless answer.
I touched on that, having been in the same practice and starting with, well, we were all doing quite aggressive preps. We would offer ortho, but ortho would classically be a year to 18 months. We didn't know that we could just do anterior tooth arrangement like we can now. So we were used to heavily prepping and it was fine. But what I found was after 7 or 8 years, these units were popping off. And I mean, I'm a 4th generation bonding guy. I'm OptiBond FL. I was using the same bond then. I don't think it's about bond strength. It's about the enamel, and longevity is enamel. So I found after typically 7 or 8 years, the units were popping off, and I wasn't sure why. And then we realized that for longevity, we need to be in enamel because that is a permanent bond. And we all know the water trees, and that's what it tends to degrade. And I believe in dentine bonding. I've studied with Pascal. We've done IDS. So I understand all of that. But if we're going to be certainly elective treating patients, we need to be as minimal as we can for the longevity. And we all talk about a 10 to 15 year lifespan. I think that's fine. But the purpose of that for me is so that someone understands that it is going to have a lifespan. It's going to fail eventually. But I think bonding to enamel, I've got cases that are going 20, 25 years because they're bonded to enamel.
Hope you enjoyed that one. Next up, when I had Dr. Audhan Doherty on to talk about temporary veneers in February, I asked him about papilla health and how to avoid bleeding at fit. Here's the brilliant tip he shared that changed how many of you now temporize.
So what we want to see when you've done temporization correctly is you actually want to see little spaces above the proximal papillas, and those little spaces are going to allow you to feed an interdental brush, such as a Pixstar or any of the other interdental brush brands. But I use a Pixstar. I don't know if you guys have Pixstars, but
It's like a plastic one, right?
yes, it's the smallest one. It's a little interdental brush, and I use the smallest one interproximally. And you should, when you've done your temporaries nicely, you should have a little space above, or incisal to, I should say, the papilla. And that's your space that you can feed.
Like a tiny black triangle.
A tiny black triangle. What happens if you don't have any space? You're going to have inability to clean proximally, and you're going to have a nightmare for your issue appointment, because one of two things will have happened. You'll have crushed your papilla, and you will actually induce necrosis, and you will actually induce an actual black triangle. And also you're going to have lots of bleeding. So it's not good for anyone.
Moving on now to one of my favorite topics, digital dentistry. In May of 2025, I asked Dr. Rustam Mupin the big question every GDP wants answered. Is chairside milling really worth the investment? This was the moment he explained the true ROI.
There's a measurable ROI, and you think about it like it makes you money. It makes you money, and it makes you better because you're making your own work. Okay, so your preps get better straight away because you're designing everything, you understand things better. And you also got to think that immeasurably, because you're faster and everything, because you're doing things the same way, then you're getting paid more to do the same thing. You're saving on time. Again, time, it comes back to time, and that's important. But yeah, easily. And not just that, I paid it off 5 years ago. So I updated my Omnicam to a prime scan, and I paid another 28k for that as a trade-in. But literally every crown I mill now, like the other day, one of the reps, he gave me 2 sets of blocks. So that's 10 blocks, right? And I'm like, this guy doesn't realize, but he's basically giving me £8,000.
Yeah. So how much does it cost you? I mean, obviously not including software and that kind of stuff. Just the milling fee itself of one Emax, how much does it cost you? So let's say my lab charges me £170, let's say, $300, whatever. How much is that unit costing you?
So a block of Emax. So there's chairside milling and there's lab side milling. Okay, and so if you buy a chairside unit, everything you buy is going to cost you like roughly 5 to 10 times more. So if I mill a block of Emax, then it costs me about 30 quid. Okay, but if I mill a puck of zirconia, you get these discs of zirconia that you put in your 5-axis or whatever, right? That puck is about 90 quid, and I get about 16 restorations out of it. And I have to center it overnight and stuff. But you got to really think like it doesn't cost a lot of money to do. And if you're doing bigger cases, like for me, I do a lot of indirects. And if I outsource a lab, like it would cost me easily like 20-30 grand a year, like easily.
Mm-hmm. Lovely. Next, with Dr. Ash Soneji, in September, I asked whether dentists should ditch their DSLRs and move to mirrorless. Here's where Ash explains why many mirrorless camera lenses actually fail clinical photography.
Depends where your budget is, but an interesting thing that I saw on Sony Online was the Sony A7 Mark III, which is originally a 1500 body, has dropped to 1000. Mm-hmm. So if your budget is stretching to that, the setup that I would get, if your budget is around kind of 1700, is to go for Sony mirrorless, either go full frame. I would say go full frame. You'll have much more versatility. You'll get better shots. And seriously consider the Alpha 7 Mark III. The price of that has just dropped
to 1,000.
Right? 1,000 for that. And you're looking at the actual lens that works with this mirrorless camera. So you're going to get a lot of the optimized technology. That is a 90mm macro lens, and it works with a mirrorless camera. The computer speaks to the lens really well. It's got amazing image stabilization. It's one of the only actual cameras of its mark. I actually have the lens here, and the really important thing is the barrel of the camera has actually got markings on. Mm-hmm. So this is super important. There's quite a few new mirrorless lenses that don't have this. And why is this so important is this is what will allow you to have standardized images.
When speaking to Dr. Seth Atkins in July, I asked how a GDP can throw away the Facebook and digitally get an accurate mount. This clip contains the most powerful answer.
We did that with the earbow for a long time. And we've got a lot of literature with the regular Facebook that, on a good day, it's going to get us within 5 millimeters of the true hinge axis, which sounds like, okay, we're pretty close in doing it. But now that we've got this digital data and more things at our disposal, many times now we're using a CT initially to do that hinge axis relation. And it makes sense because, the Facebook, the whole point's to capture the maxilla relative to the condyles. And if you have a CT of adequate volume, you've got the condyles, you've got the maxilla. If you take that scan in a seated position, all the anatomy is there that you need for the relation. So how I'm doing that today in the digital side, if we're not doing axiography, and I'll kind of get off on the nuance of that in a second, you're aligning an intraoral scan to your CBCT. And then once you do that in the software, you can move them as one cohesive unit. So then I'm overlaying that on the virtual articulator, and you just position the condyles of the patient over the articulator condyles, rotate it till the infraorbital planes parallel the upper member, and you've got all the information you need done with it related.
I've had many questions from you about raising vertical dimension safely. So when Dr. David Bloom joined me also in July, I asked him early on in our career, how do we know the correct amount to open the bite? Here's the exact moment he broke it down.
We don't always know how much we're going to open. So the most important is that you have a bite record at CR. And then the technician is going to work out what space they need. And anything I provide them with is an estimation until they start waxing up the case, whether that's a typical analog wax up or absolutely a digital wax up. And so two different ways, but for the less experienced, the safest is to give the lab a bite record at your proposed increased vertical.
I'm just writing that down now. That is exactly it.
But that isn't always possible. But as long as they're in CR, the lab can adjust that because they're going to work out what is needed. And then they're going to make a bite jig at that and that increase.
One of our first episodes of the year, in our ceramics episode with the Protrusive student Emma Hutchison, she asked me one of the most important material selection questions a GDP faces. When should I choose lithium disilicate and when should I abandon it for zirconia? Here's the exact moment I break it down for her. Feldspathic is a type of ceramic, basically. It's a very beautiful ceramic, traditionally used for veneers. Not so much anymore because the number of technicians who are skilled at this is less and less and less as we're going more CAD CAM and whatnot, and then labs are going more digital. But essentially, these veneers are beautiful, but they are weak. Something from my mind, I remember like 90 megapascals, let's say, right? So they are weak compared to 250, 300 megapascals of lithium disilicate. So they're weak, but they're beautiful. But once you bond them to enamel, they are so strong. It's a bit like a tile, a glass tile. Like if you drop the tile, it's going to break. If you actually glue that tile on the floor, it is strong. Yeah. That was the analogy that was given to me when I was a student. I still remember this basically. So using lithium disilicate posteriorly and bonding it, excellent strength, good. It's going to be fine as long as you give it enough thickness, 1.52 millimeters. You're golden, okay? If you don't respect the thickness, or if you use cement and you don't bond it, you're going to really compromise on the strength. You're not going to get the high strength. So therefore, the same material, lithium disilicate, cemented is a completely different ceramic to the same ceramic lithium disilicate bonded. When I had Dr. Lane Ochi on the podcast in August, I asked him what to do when you simply don't have space for a ceramic crown. His answer was a refreshing reminder of how powerful metal still is. Here's Lane explaining why gold and chrome sometimes beat zirconia hands down.
This is the beauty of nickel chrome. 0.5 millimeter is more than enough, right? Obviously, if you're going to use type 2 gold, 0.5 millimeter is not enough. If you're going to use type 3, depending on the parafunctional habits of the patient, you're probably okay, but they will wear through it. And so you go to type 4, which is, the hardest yellow gold we have. But yeah, with the materials you're using and just 0.5 millimeter is fine. We could expect good.
So with the ones with the non-precious metal I'm using, 0.5 mil, which is great. Yep. But then when those who are using gold, you said, just remind us again for the younger colleagues, type 1 is the highest gold content, the softest, not used very much, type 1. Type 2 is more for inlays. Type 3 for gold and frameworks. Sorry, for onlays and frameworks. Is that right?
Yes.
Crowns and frameworks?
Yes. Yeah, that's a good, kind of application. And type 4 is the hardest noble gold. And so, when you don't have a lot of room, 0.5 millimeter, it would be well indicated.
In July, I asked Dr. Brandon Mack why GDPs often avoid cosmetic cases and what separates great cosmetic dentists from hesitant ones and how to create a symbiotic relationship with the lab. Here's Brandon's powerful insight.
I think that you said something there, and I think it really boils down to the fear. Why people don't want to take more creative risk, it boils down to fear. And this idea as dentists, we're so type A that we feel like everything is a Super Bowl. We have to get it right on the first attempt. What many people don't understand is that even when I've identified someone that I would note as being the best in the world, it takes a minimum, and I don't even think this is an overstatement, I think it's an understatement, a minimum of 15 to 20 cases to dial in a particular language until there is a certain homeostasis that's happening there where you are just in the zone, oscillating back and forth. And a lot of people have to be okay with taking that risk. They have the fear that we're not going to get it right this first time. It's like there's certain indicators. How do they fit? How is the communication? Are they open to feedback? Do they give you feedback? Because if you have that type of relationship, exactly like your mentor told you, the prosthodontic technician, it is about getting with someone that you can grow with. And I think it takes 15 to 20 cases to build a body of work. And now you can reference those cases when it comes to color and texture and design. That's really important.
I had an amazing conversation in October with Dr. Wyman Chan, the king of whitening. I asked him the simplest way to stop sensitivity. Here's the clip that changed many of your protocols overnight.
I advocate actually a coin of a phrase called conscious bleaching against unconscious bleaching. Because a lot of us are giving them 10% carbon monoxide, which is supposed to be the gold standard, according to the ADA, American Dental Association. It's been there for so many years. I think it should be upgraded. And a lot of people are using 16% carbon monoxide, which is equivalent to 6% hydrogen peroxide, the maximum strength we can use in the UK. I like conscious bleaching because if it hurts you, you know. Somebody pinch you, you know it hurts. Mm-hmm. Like if you're unconscious during a night, you're fast asleep, you only have the pain the next day. And then you talk about over bleaching, and that is very painful. Mm-hmm. So I prefer daytime bleaching, which is the patient in control. Mm-hmm. If the patient feel anything that is not right, for example, a certain twinge on the nerve, you know that is over bleach. You stop straight away, take a trace out, wash it off. That's it. You won't have any more pain. Mm-hmm. So it's conscious bleaching.
With Dr. Nick Yanios in September, I asked him why so many perfect restorations still come back sensitive. His explanation of sympathetic dental hypersensitivity blew my mind. Here's the segment.
When they bite down and grind off to the right or to the left, on the T-scan sensor, you're studying 3,000 of a second increments, like what hits when, okay? So it's almost like if you're an MIP and you're chewing your food, grinding around, milling, maybe not quite touching, there's still contact happening. I want you to think the sideways excursive movements like speed bumps. The more speed bumps, the more likely the nervous system doesn't like all that extra bump, 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 bump. So you want to kind of smooth out the ride when you're going left and right. Imagine you're in a car. You want it to be a little smoother. So fewer bumps is a good thing, right? So it was based on timing. And he was talking about lactic acid, burns, all these things. But long story short, I'm applying his DTR principles in a private practice, real world. And I'm starting to notice that as I'm adjusting bites, you know, maybe they came in, they had a problem with a crown that the guy down the road did, or maybe I did the crown last month, right? And I'm using the sensor and I'm applying his principles. And I'm starting to notice they start out really cold sensitive, water and air from the handpiece. And then all of a sudden it drops down to almost nothing.
When teaching the fundamentals to Emma Hutchison in October, she asked why a beautifully filled RCT can still fail. This was the moment I explained the 80/20ths of Endo success. You might just, by using saline as irrigation, by just sticking a couple of files in there, sticking a GP cone in there, maybe, I'm just postulating, maybe you will get 50 to 60% success rate just by closing it up, giving a coronal seal, and you might get 60% at 5-10 years, right? Still, that's a lot of failure, but when you're trying to aim for the success rate that endodontics does thankfully enjoy, right, which is 95% plus, done well, and in life, that's what we want to be at. That's what we want to aim for. And that's those little things which are the big things, right? Rub dam isolation, doing it properly, not just with the radiograph, right? Using the correct solution. And just, you know, if you get the basics right, it's like Pareto's principle, right? 80% of your effect comes from 20% of endodontics. So 20% of endodontics that have the 80% effect is rubber dam isolation, using hypochlorite, and respecting the structure of tooth and not being overzealous with being conservative. If you do those three things, then that is a Pareto principle of endodontics. You get the 80% of success by just doing those three things. I recorded 2 episodes with Dr. Samuel Johnson in March. In part 1, I asked why files sometimes refuse to go to length. Here's where Samuel explained the phenomenon of file gripping.
If you are getting, say you're 18
on a canal, and you know that it's probably about 20, 22. The best thing for you to do, if you're getting stuck, the best thing to do is not to jam it down there. You're going to pull your hand file out. In fact, you're going to measure first how far you've got with the rubber stopper. You're going to take it out. You're going to measure it. It's 18. You're then going to get a higher diameter file. Okay, and this could be anything. Say you're using a size 10, you just get 15. Me personally, I like to use these glide path files, and then I measure the higher diameter file 17 millimeters, so 0.1 millimeters away, and then I'm gonna shape it with that. Then, personally, what I do is I get my master apical file, and then I shape it at 16, so 2 millimeters. Listen, you're not using more files than you would do. You're going to be using this file later on anyway, so you might as well just use it to shape it up. And what you're doing is you're releasing the grip of the canal further up the shank of the file, further up the file.
In part 2 with Dr. Samuel Johnson, I asked what to do when GP won't follow a sharp apical curve. This quick pearl is absolute gold.
And another really, really great thing about it is you can pre-bend hand files when you're trying to get around a tight curve, but you can also pre-bend GP cones. You might say to me, well, GP cones are not stiff. So in this case, yesterday what I did is I got some Endo frost, and I blasted the GP cone with Endo frost. So I essentially froze the GP cone, and I was able to manipulate around this canal. So that's another really great tip, is get your Endo frost out.
In July, when I asked Dr. Ayman Al-Sibasi how to safely remove GP in simple retreatments, he shared the exact files and techniques he uses daily. Here are the clips.
If we come back to what I said about why most these more straightforward cases, why they fail, a lot of the time, as I said, it's because the GP is already not that well condensed to begin with. So in terms of removing the GP, my first go-to in those kind of cases would always kind of be headstrong files. So the reason I say that is because they're hand files, so they're probably a lot safer than using sort of rotary files. You can control it a bit better as well. I would probably go for like a size 35 to 45, nothing smaller than a 35, because when you screw it in, I find that they are more likely to fracture. So yeah, I would go for like a size 35 to 45, something in that range. And yeah, you kind of just get your estimated working length off the radiograph. And then you'll kind of go into the top of, say, the most coronal portion of the apical thirds. I'll try and get the file down there. Screw it in just very gently. If it's not going, I wouldn't force it, because you can end up ledging and stuff like that. But oftentimes you'll literally feel the headstrong file passing down quite easily into space, or you'll feel it screwing into like stickiness, and that will be the GP. So get it down there, make sure you got your length, and then you just kind of, it's basically a pulling motion essentially. And a lot of the times in these cases, you'll find that the GP just comes out with 1 or 2 pulls of that, and it kind of just pops out with it. If it doesn't, then you can use a second headstrong file and like a braiding technique. So you can kind of put them both in together, wrap them around each other. But again, very gently, don't wrap them around too many times, because you can fracture a file inside.
In my pre-endo walkthrough in January, I demonstrated one habit that has saved me countless headaches: PTFE blocking. And now I'm using PTFE. I'm plugging this area with PTFE so that when I build it up in composite, the composite's not going to jam my endodontic access. There we are. So adding more PTFE in, and you'll see that when I get my seal using the matrix band, I can then very quickly get my composite on, or my foundation material, my core material, and then access through it, and I'll know I'm there when I get to the PTFE. In an ideal world, I wish I used like a yellow PTFE if I had it, so it's even easier to see when I'm there, because you'll see that the composite I'm using is actually bright white. It's the same color as the PTFE. So next time I would like to use, I think they're called like a gas tape. This is PTFE tape, but I think gas tape might be yellow. So you can see it's nice and neat, and I've got my PTFE blocking the canal nicely, so my resin material's not going to extrude and jam and block my endodontic access. With Dr. Omar Ikram in September, I asked the question dentists struggle with most. When is a cracked tooth actually not worth trying to save? Here's Omar's red flag rule.
When you start exploring that crack, there's a couple of things. First of all, CBCT will show you that if there's any periodontal defects. If the periodontal defect's deeper than interproximity and you can't probe it very easily, if it's deeper than 5 millimeters, it's pretty much game over, because they're going to have a periodontal disease there even when you do the root canal treatment, because that's essentially impossible to clean region and all that stuff. But if there's no defect deeper than 5 millimeters...
This is a clinical measurement or a CBCT measurement, what you're saying here?
I measure on the CBCT, because often you can't probe between the two. Yeah, so assume that if it's 3 or 4 millimeters, let's say, but you can't probe it because interproximal...
And just for clarity for the younger audience, are you measuring from the CEJ to the bone crest? Where is this measurement being taken from?
Yeah, CEJ.
CEJ to the bone level.
The depth of the pocket, yeah. You measure on the CBCT because a lot of the times you cannot get the probe into proximal and probe it and measure it. And sometimes even with those 4, it seems like less, it's not that deep. I mean, obviously you got the deep pocket all the way to the avix, then it's gone. I mean, that's obvious. But what I'm saying here is you see these defects and you go, there's going to be a crack involving the bone. Next question is, how deep is it? If it's 5 millimeters or more, then they're not going to be able to clean that, and they're going to do the best endo in the world, and this is going to be gone because of periodontal abscesses, and they're still going to get pain. They're going to get that swelling of the gingiva and all that stuff. They can't get their toothbrush out and clean down that defect.
Next up is paediatrics. I asked Dr. Tim Keyes in June why so many dentists avoid radiographs in children. Here's the clip where he explains why that's no longer acceptable, and when we should start taking radiographs on our little patients.
To know how to treat kids, you got to have done a comprehensive clinical examination, and arguably, even more importantly, you got to have x-rays. So it is medico-legally indefensible to do a restorative procedure on a child without an x-ray. I mean, we wouldn't do it on an adult. We see a lot of people doing it on kids because it's hard to take x-rays on kids. When you should take radiographs on children, let's say you got a child who's got no clinical issues, you've done a clean exam, it looks good, but you've got closed contacts. It should be taken 18 months after closed contacts. So Jazz, well done. 4 years of age. That's about when we should start taking them. It's hard. There's lots of variations you can do to the technique to still achieve it. Keep in mind, each x-ray is the equivalent of around 6 bananas, because 6 bananas got radiation in, right? So the radiation test is insignificant, really. Now, if you've got a patient who's got a clinical issue, I would encourage all your listeners, please do not do anything without x-rays. And if you can't get x-rays on that patient because of compliance issues, you really need to reconsider your ability to treat them. Because if you can't get an x-ray on them, how do you expect them to sit through an extraction or a restoration or even putting a bit of Fuji 2 over the top of it, right? Over RMGIC. So you need to get x-rays.
In our oral surgery episode in January, I asked Dr. Neki Jamal how he differentiates normal healing, dry socket, and true infection. Here's the exact clip that every GDP should memorize.
This is when the patient comes in, right? You're like, okay, they have pain. Do they have swelling? And is it a dry socket or is it an infection? Okay, so I always want to remind everyone the 3 cardinal signs of infection. Okay, pain, fever, swelling. But everyone has pain, everyone has swelling. But do they have a fever? Okay, so that's like a cardinal sign. That's how you know it's infection. And also swelling. After day 3, shouldn't swelling be going down? If swelling is progressing past day 3, you're like, oh, okay, could that be an infection? Is there a fever? You know what I mean? That's where my brain is thinking. However, when you look in the mouth, if they have, a large dark hole, which a lot of people do, you can't just jump and think it's dry socket. But how good is their oral hygiene? Is there a ton of food debris in the socket? Does it stink? Do you know what I mean? Is it extreme pain in their ear, down their neck, and there isn't swelling, swelling has subsided, there isn't a fever? Well, then I'm thinking dry socket, right?
Now onto a favorite topic of mine, TMD. With Dr. Susie Bergman in January, I asked her what actually helps patients with TMD when the evidence base leaves us hanging. Here's the moment Susie shared the simple daily habits every GDP should be teaching to their TMD patients.
The things that we do know are that self-management is very powerful. Things that don't sound that impressive, like hot and cold therapy. That is safe. It is effective. Things like physical therapy, as you said, I feel my physical therapist, she has magic in her fingers. And I always say she makes me look good because patients come in and I tell them, I really want you to see my physical therapist. And they come in the next visit with a huge smile on their face and say, I'm already starting to feel better. I'm understanding that I have exercises that I can do. I give them lots of acronyms. I'm an acronym girl. So I tell them tattoo, which stands for teeth apart, tongue up. So during the day, as much as possible, try to keep your teeth away from each other so that you're not clenching. I tell them we want you to do the 3 S's, which are softer food, smaller bite, slower chewing, things that put less of a load on the joint.
Continuing the patient management theme, in my conversation with dental student Naveed Patti in April, he asked me what makes fee discussions difficult for dentists. Here's the clip where I explain why ditching jargon is the fastest path to patient trust. I'm not saying dumb it down, but is that really, appropriate? So if you feel as though the patient has that level of language and you've sussed that out, then absolutely, because I'm a big believer in that modified chameleon, and therefore, I'm gonna speak like this, innit? If I see someone, who's from the street, I'll be like, bruv, listen, your tooth needs to come out. And and very much, I go like that, right? And that's fine, okay? And then they respect me a lot, and we get it, okay? I don't actually do it in that extremity. I was a bit of a dramatic effect there, but I'm very much like, if the patient wants to fist bump me, I'm gonna fist bump them, right? So you gotta really meet them where they are. And the best person I saw do this was Raj Patel in Sheffield. Like, when he saw a patient who was a gardener, right, he would literally describe, just like that, in such a wonderful way, he would describe everything that he was doing in dentistry, like in gardening terms. If you had a builder or plumber, it was the most magical thing ever. And I learned a lot that day seeing that, right? Now into medical emergencies and post-op complications in September with lead nurse and educator Rachel King Harris. I asked Rachel 3 key questions every dental team should know. 1, what's the first thing to do in a faint? 2, how do we quickly differentiate faint versus cardiac arrest? 3, and when should we give adrenaline in suspected anaphylaxis? Here are her rapid fire answers.
When you faint, essentially your blood pressure drops. So that quick event that happens, what you need to do is actually try, and I don't know whether your dentistry beds tilt, but tilting's actually the best. So our medical beds in hospital, we can tilt them like this. So
like left and right?
Up and down. So that their feet literally come straight up and their head down.
It doesn't tilt, but we can actually do it so that the head goes below the legs.
Perfect.
So we can do
That's exactly what we want. So we want the head down. And then if the bed's not quick enough getting up or it's not working or whatever, you actually can just manually lift the legs and hold them up, or get their relative if they've got a relative in with them or somebody that's come in, and then just keep them like that. I guess my advice would be is checking, because what you worry about with a vasovagal is that because they have those like moments of unconsciousness, is this actually a cardiac arrest? And what we tend to happen in hospital is that we start shaking the patient and checking their breathing to make sure that we haven't actually caused, or the patient hasn't gone into cardiac arrest. So the advice that we kind of give our colleagues in hospital is you check the breathing, and that's the most simple thing to do. So you lay them flat if they're not already flat.
So let's assume that you think it is a vasovagal simply, but you're a little bit unsure and you're a little bit scared, and so you do the first step anyway, to lay them flat, which works for both.
Yeah.
And then next step will be
open up their airway. So head tilt, chin lift. So really pull that head back, making sure that as long as they've not.
So we got this little headset here that is handy to bring the head back.
Yeah. And then you look, listen, and feel for breathing. And as long as you can see that chest go up and down, that's breathing. So then you pretty much know then that this is actually a faint. Exactly the same. So the patient was short breath. I was like waiting for the rash. And then they didn't say it was a rash. So I kind of went down the wrong path. But so don't wait for the rash is my kind of top tip, because actually if you've been stung, you've got upper airway stridor with some swelling, the patient feels terrible, you can pretty much go down the anaphylactic route with this one. So they fortunately recognised it very quickly in the dental surgery, and they got their emergency kit out and they administered the correct dose of adrenaline, IM adrenaline.
With oral surgery consultant Dr. Pippa Cullingham, I asked her in March the one MRONJ question every GDP should know the answer to. What are the real risks, and how do we communicate them honestly? This clip gives the clearest summary you'll ever hear.
So I'd say overall it tends to be the condition that affects the risk factor. So the patient's taking a bisphosphonate or an anti-angiogenic, because that's another group of drugs that can cause the MRONJ, tend to be slightly higher risk than maybe your osteoporosis patients that are prescribed a bisphosphonate. So increasingly, it was thought that looking at larger studies that patients prescribed a bisphosphonate for cancer were at about a 1% risk of developing an MRONJ following a dental extraction. There's been an update, so it's closer to 5%, we think.
Wow.
But we're not sure if that's because there's increased follow-up, increased awareness, more reporting of the condition. So closer to 5% on the cancer patients. For an osteoporosis bisphosphonate medication, it's around 0.1, 0.2, so it's a low risk.
In February, I asked Dr. Beant Thandi what advice he'd give new graduates in order to fall in love with dentistry and find their niche. This was his number one answer.
And that's a tip, I think, for all FDs having just pretty much come out of FD. The photos I took, even though they're not the best, I'm not really going to post them anywhere. They're for myself.
I think you posted a few in our chat group, I remember.
I sent some privately, yes, so sort of like with the group chats.
Okay.
But when I say publicly, I mean I wouldn't post them on like a Instagram or something like that at the moment. More for like self-growth, really, is the focus of them. Just asking for like opinions and stuff. And
Reflection, getting reflection, seeing what you did well, analysing afterwards.
Yeah, exactly that. And I just found myself getting absolutely engrossed in my dentistry, really analysing things, and I was enjoying it. And I realised how much, even with loops, you don't see compared to the photos sometimes. And it was really good to help me really improve. And I really took pride in that. And I also used that during my FD to make sure I felt like I'm at a good enough standard of general dentistry for where I feel I need to be.
In our Associates episode, also from February, I asked Dr. Kiran Shakla about her mindset when it comes to learning from those around you, including our experienced nurses. Here's a brilliant clip with her advice.
So I think when you're in this position, you have to think, who's been qualified for longer in the dentistry profession? You or your nurse? And especially when you're starting out, your nurse they've worked with so many different dentists, they've seen so many different things. They know what works and what doesn't work, So sometimes, you just have to ask her. Even now, I still work with that same nurse, and we were doing a veneer prep case a few months ago. And I said, okay, run me through what the boss does. And she was like, okay, he does it like this, he does it like that. And then on that day, I said to practice manager, please, can she be with me? I want her to be in the surgery, assisting me. And she helped me out. She was like, oh, Kiran, you've just missed this bit, or drop the margin a little bit. Or even when we do composite bonding, I always say to my nurse, what does it look like? How's it looking from your side? Because from my side, it looks okay. And then all my nurses are trained now to actually tell me, oh, Kiran, you've missed a bit, or it's looking a bit high here. You need to polish that back. But I think with this nurse, she was quite confident. She was like, I'm going to tell you how it's done. And at that time, I wasn't the most confident dentist. So I kind of took it on board. But what you said with these anonymous posts and stuff, don't feel afraid. These nurses have more, they don't have the clinical skill, but they've seen so many people do it. They know what works and what doesn't. And if you get on with them, and if they can teach you something, it's like going on a course and I could have paid to go on a course for someone to teach me how to do that. But why would I when my nurse has seen it done 100 times and she's like, Kiran, this is how it's done. Come on, I'll help you. And if they're willing to help you, it's like another mentor, right? Just because they're a different job title to do doesn't mean that you should see them any different. You're a team. You work together.
When discussing well-being with Dr. Simon Chard in February, February was a popular month. I asked him, what's the one habit that gives dentists the biggest bang for their buck? Here's Simon's smile insight.
The way I structured this, because obviously I'm a dentist, I've got a nice little dental acronym, which is SMILE. It's part of a broader thesis, which is called Great Smile. Great is more towards building fulfillment in your career, but we can touch on that later maybe. But for SMILE, it basically stands for sleep, mindfulness, intake, love, and exercise. And those pillars, for me, if you can get those in balance around your dental life, you're going to be a much more resilient individual to be ready for whatever life throws at you.
Our final clip of today with physio turned dentist Dr. Sam Cope. The most important thing we need to look after is our neck and back. I asked him back in April what actually protects dentists from back pain, and his answer was refreshingly simple.
If you want to be in a position for a long time, your muscles have to be very conditioned to do that. If I said to you oh, you're going skiing next week, you wouldn't be practicing your posture. You'd be practicing, you'd be doing squats against the wall. You'd be kind of getting your legs conditioned. If you're going to do a sport, you're going to want to condition your muscles to be ready for that sport. And that's exactly the same for dentistry. You can be in those long positions. You can sit for more than 30 minutes and it's not a problem. You just have to condition yourself for that. So say if you are a student and you've not really done any long procedures before, and then you go into doing dentistry and all of a sudden you've gone from being on your summer holiday to then starting your foundation dentistry, and all of a sudden you're seeing 20 patients and you're sat on the chair and you're a bit stressed, you are much more likely to get back or neck pain because you're just not conditioned to do that. But after a period of time, after say, a month or two or something of doing it, it'd be much less likely for you to get back or neck pain because you have conditioned yourself to be in that kind of routine.
Let me know in the comments what you thought about the AI voice. Now, this episode wasn't eligible for CE, but over this year, we had over 40 hours of CPD or CE. We are a PACE approved education provider. And so that means for 2026, we're also going to have 40 plus hours of new CE just from the podcast episodes. On the app, we'll be do our masterclasses and special webinars, which also count towards your CPD, there'll be another 30 hours coming on just the app if you're an Ultimate member. Plus the access to 400 plus hours of all the last 6 years worth of CPD. So there's no shortage of quantity of CPD, and I hope you like the quality that we deliver. From the new stuff to the old stuff, whatever you want to grow in, whatever you want to learn, I hope that Protrusive will be able to help you in 2026. Now is a great time to join a Protrusive membership because we have Ask Jazz. So Ask Jazz is being bundled into the Ultimate membership. After 12th of January, it's going to have its own membership, and quite rightfully so, it'll be about $1,200 US per year. That's how powerful the AI is. But just now, we're bundling that into the Ultimate education plan. So anyone who joins 11th January and before will get Ask Jazz included forever. As long as you're a member in good standing, you get access to Ask Jazz. It's part of our commitment to making this the best value subscription you have. So if you're a community member or you've been sitting on the fence, now is a great time to upgrade before 11th of Jan, so you can get Ask Jazz included and literally like 24/7 mentorship. You can call me anytime and I will speak back to you and I will give you what you need. And of course, we're constantly making it more and more powerful. Check out the link in the show notes or the description below to join us in the app in the nicest and geekiest place for dentists in the world. Thank you to Team Protrusive for doing this one while I was away on holiday. Thanks to all the guests that we've had on the show this year and all the years. And thanks to you, Protruserati, for your support and commitment to being the best dentist you can. I'll see you in the new year, same time, same place. Bye for now.